this is my lovely Madison. It's actually freaky when you hold her. I don't know if you've played with a silicone doll, but you'll actually want to protect her head because she'll flop back. And I was reading a book on Einstein to my son, and it was the image of the space shuttle rotating out. You know, we were just talking about escape velocity and that kind of thing. A couple of hours later, I literally jumped from my bed and I said, it can't be that simple. And my husband was like, where are you going? And I'm like, I'm not that smart. I'm not going to remember this in the morning. Literally at 11 o'clock at night, I'm just typing about 6 paragraphs of what just happened to change everything. And I realized with all my practice, I work with some severe people, especially the children. I've worked with chromosome deletions where there's only, even my own son, I think there's 40 of him in the world. I've paid attention. The common denominator with all these kids was the lack of, or the inability of rotation. So whether it was traumatized, or due to their genetics, it's non-existence, or whatever is that flavor that you're looking for, rotation was the key denominator, from cerebral palsy to autism to ADD as being the most common, to rare genetic disorders. And I realized I naturally touch with rotation. So it took a good 2, almost 3 years to formulate it out, but I went back to the source. Why are all babies born the same way? A typical vaginal delivery has a key rotation, which some people have thought. There's some chiropractic principles that actually want to take that rotation out of you. And I'm like, no, you know, it's there for a reason. I get it. It can be traumatized when you're using suction and forceps and all of that. Too much Pitocin, too fast. Like I delivered my son at 4.5 centimeters. I mean, like that sucker just came out. And they're like, oh, the Pitocin was too high. Well, yeah, that's fine time to find out. So, and again, I had a child before. I wasn't the completely dimwit, but, you know, I kind of know when I'm about to have a baby, and she's like, no, you're not dilated enough. Well, guess what? That baby came and made his presence known in my body and its own. And so that's the way it is. But my son got sick at 13 months and didn't get better. And I kept going to people, and it's like, well, we don't know, but guess what? You know, and I could not believe, looking back, that no one had any kind of way of looking at short or long-term development on that child, that there were no official assessments. Yes, if your child's that bad, a PT will come in and assess your child, or a psychologist or whatever, but not on a pediatric visit, not on a, and if I had known I was looking at long-term complications, I would have been much more aggressive. But the biggest problem is, first of all, is a parent naturally won't complain about a baby. They might be a little colicky, I'm not getting sleep, whatever. They're sleep deprived, so that impairs their judgment. They figure the baby, there's not much going on birth to 3 months. I mean, even what to expect, expecting, again, not to fault these things need to step it up. They don't talk about movement until page 99. It's all about how to get the right bottle, car seat, and that's it.
Yeah.
One of the things I want to document, and again, it's in my brain, but I have to get it out, is the developmental movement patterns that happen during the first 3 months, the significant ones and the ones that are typical and non-typical, and then what are the significance as if that road is left untouched, what's going to happen to that child, so they can start looking. I kind of had an argument in India. I went to do the assessment first on a baby that was in phototherapy. Oh, don't worry about that baby, it's fine, it's just jaundice. How do you know it's fine? Why is it going into jaundice? Jaundice is not a typical response for the baby. That's not or their system is already saying, I'm in trouble in one way. And what if it goes into a whole bilirubin thing that you're not catching? I have plenty of my clients that, you know, they didn't catch the RH factor. I don't know how that's happening in this day and age. And you're looking at severe CP. What if the liver is going into complications? At least you have a baseline. The APGAR score, nothing wrong with it, but is there to direct a nurse to the doctor. Again, it's not for long-term care. There's a very interesting study out of Norway that 89% of their babies with CP had high APGAR scores.
Oh, wow.
So the discrepancy is there. So the need for the newborn assessment is huge.
Yeah.
I specifically went away from movement lesson for this book because I knew a doctor wouldn't do also therapy at birth, to find a way to just briefly assess the baby. A parent can do this as well as a professional. So the need for Mommy and Me classes is imperative. The need for all of that is really important. And again, clean and simple. I had to write a book that a 16-year-old mom could understand, but a professional would be interested to see the benefit. And that was the hardest thing. There's no prone, there's no supine, posterior, nothing like that. Because most people, again, are not looking at that kind of vocabulary unless there is something wrong. But the first sign of developmental problems is the lack of sitting up. And even most doctors believe there should be a window from 6 to 10 months where the child should be able to sit up on its own. And I'm like, if you're telling me at 10 months going, oh, I think there's a problem. We've so missed the boat for that child. And now we're looking more at long-term concerns. So whether a baby is born addicted to drugs, has a chromosome problems, I don't care what the issue is. From day one, you can enhance their lives. I truly believe if every baby got assessed like this and got 2 lessons right at birth, we would bring autism back into its normal ranges. We have Madison here, and I'm going to be going over this assessment through every baby, so you'll see it in various stages. This assessment can be done on a 60-year-old. That's the next thing I want to do is for the anti-aging is to check the rotation, because again, you don't want to succumb to gravity either. I mean, like I said, what we're working with here. You're literally going to choose a pelvis. You can learn how to handle it this way. You know, there's different ways of approaching. The one thing that you'll never see me do is where I grab the system. And I'm going to show how this affects every one of us. Your touch is going to improve so much, whether it's from petting your dog to delivering a baby. Especially, you'll see a lot of people do this to check hips. And this is really not good, because what you're doing is locking up that rotation. So knee, I do knee. Some people like to do right, you know, very specific down the line. I honestly can assess a baby just by doing this and looking at you. I know because of the way the movement comes back. But that's just years of, and that's where again these neonatal nurses, a lot of people can see things going on, but to actually be able to articulate in this clean, simple language that again...
That's what I'm thinking. I think they might have a lot more success, you know.
Right.
Yeah.
Especially where I'm trying to stress is the needle nurse is busy.
I know.
Mom,
I know. But you should have heard this lady, you know, like she had case after case after case where she would look in to people she knew and say, you know, problem. Big problem.
Right.
You know, need to do something right now.
Right.
I mean, not that you and me wouldn't do that too, but you know.
Well, I'll send you home with an extra book if you can.
Be great. I will give it to her.
Yeah.
I definitely will give it to her.
So again, I'm just here on the foot. Big flag. You do not want the foot to be a windshield wiper. The heel, and again, I'll be getting into this. I'm really just sort of poof, and then I'm going to back off and then teach you all of these kind of things as we go. The heel is a midline. So is a trochanter. So with the rotation, what you want to see is the crossing or the ability to cross midline. So that the hands and the feet, the hands are harder to tell right off the bat, but they should almost form like that X, that counter. And see, that's what happens, the knee counters. That is the beginning of side sitting, even if it's just in the baby. So if the baby's only doing this, it's no surprise to me later on that this child is either going to W sit because of the way that the foot's going, or there's no way it's going to side sit because of just the way that it's presenting in movement. Now, Coming under, you're going to come under to the spine. And just do a little, just to make sure that twist is there. You'll see a lot of the babies today are going to startle. They're going to startle because, again, that chest is another midline right here, cannot cross that midline. And basically it's the wet tissue. The tissue, the lung should be able to come over and present onto the chest cavity from the inside. And not only is this traumatized, let's say, and if it's not caught, now you're sleeping babies on their backs.
Could you show us again that move of checking the, I know you'll do this over and over, but
That's okay.
checking the turn in the spine, like you just did.
So there's different ways of doing it. I'm doing it here from the pelvis. I kind of look at, I go back to karate a lot. I'm deflecting the movement versus
like how far does it go up into
manhandle.
the shoulder? Or the...
A baby is 85% liquid. That baby should just like this.
Yeah.
You should be able to touch the baby and you will see the movement going through it, just like you would have a cup of water. So right here, you'll start seeing, especially if you're working with a lot of babies, like a heavy baby's not a good sign.
A heavy baby?
Heavy.
Heavy, okay, you're right.
So they'll literally be like, oh, like you'll feel, obviously, a stiff baby. If the hips aren't rotating, just that alone, you'll actually have to assist the baby. If that baby can't cross midline through the chest cavity, she'll see the startle start to come in.
Yeah. I mean, a lot of this stuff I think we already know, but we don't have words for it.
Correct.
You know, isn't that your experience of it? Like when she talks about this, I know I felt that before, but I didn't know what to say what it was.
So another way of looking at that twist is taking the child this way, let's say. And again, excuse me that I'm manhandling Madison a little bit different than a baby. Just this way is a nice way of doing it.
Yeah.
Underneath the head. Now, any concern for torticollis? This is where you would do it on both sides. Wow, this shoulder looks nice here. But on this side, and again, I'm being a little bit rough with Madison, but it might be a bit more like, and you're going, wait a minute. You start to see the discrepancy or the symmetry being off. I get it, the baby might be asleep and all of this, but again, a baby has no judgment. If I touch you a certain way, you will judge me. That was nice, that was, and what's she doing here? But these are adult cognitive responses to movement. A baby's only job is to respond to stimulus. And the only way that they can respond to stimulus is with rotation. So when there's no rotation and you start to see the stiffness or the hand started to flail, well, how eventually is it going to go grab a ball? It's saying don't fall. At this stage, it's just protecting its basic right of development. Coming underneath the head, basically you'll just be here and literally like you can scoop in, or you can come here. This is more where I'll be at. But some people like to do the full lift, and that's fine. Again, they're little munchkins. So again, here, I can literally be under the shoulders and see this. Too, sort of. And the neck. And also, I get a good idea of what the vision's doing. Now, obviously, a baby's not going to have their eyes open. However, one of the key things, and I'm going to show you some really neat videos on this, is how the eye will counter with the body. These are two little orbits, the eye sockets, and basically have little water balloons in them. So basically, any movement I make, the eyes should counter my movement and also should counter with the pelvis. You'll start to see these counterbalances throughout the system. So if there's any kind of contractions, you ever see like a worried baby?
Yeah, I think I have seen that.
All those facial contractions. Let me tell you, a worried baby is not going to walk well because that contraction through here is going to affect the pelvis, and so they're going to march more than they're going to walk.
I'm bringing my baby videos in.
but these kind of things, as a doula, right? You're used to seeing, like some little babies come out and they look like little old men or women. They're like
totally, yeah. And then you see it in the breastfeeding big time, and then baby's allergic to milk. Mom's milk, and it's like, no, baby has pain or something's wrong.
So from here you can be here. Now see, even look at Madison. See how Madison counters? This is why I love this doll. That's what a baby should look like. Now again, they're babies. They'll have, I call them infantile spasms. People argue with me because that's a seizure. Yes, it's a seizure if that, again, that spasm hasn't matured out. You should not have infantile spasms at a year old. But a baby will have spasms. They will just go, they'll have these random movements. I believe, again, this is a myosin-Atkin things, which I'll be getting into as well, because when they have a muscle contraction, they'll have stored energy. Well, that energy will have to go out. So have you ever seen those old tops that sit down? One of these days I have to get one of these.
Oh, yeah, I've seen
and you
that.
wait, and the energy builds, and they pop up. Well, that's what sort of a baby system is doing. They'll get these little, but we can go in and out of our muscles. They don't know how to do that, so they'll suddenly get these kind of things. But you want to see them where the fingers come out. Again, where they're starting to oppose gravity with their fingers. That's the first play that you'll see. The toes. So again, you'll see one of the things of getting tons of videos on, which I'll show you, is a C-section. The doctor will grab the baby. They're hand dominant. So a C-section, the baby will come out like this. They'll have one thumb that's harder than the other. And they'll literally be grabbing that baby. And so now at 4 or 5 months, now this arm's not hardly moving.
It's amazing what a little thing like that could do, huh?
A baby will not do anything that's difficult or that hurts them. So if
they actually were hurt.
Yeah.
Oh.
You've made it difficult for them.
Yeah, right. It doesn't have to be.
I'm not saying that C-sections don't happen. They do.
Yeah.
But we are the highest country ever. There's articles out there already. New Jersey has the highest rate of C-sections, the highest rate of autism. I wonder if that's a coincidence. It's like, yeah. So, but again, half of this is not to find fault in any of these procedures, because the medical community will shut you down. It's to sit there and go, you might want to consider doing that way. Or when the baby's coming out, even though it's a pressurized birth or an emergency birth, this is much more of a better containment where the thumb's out and the head's supported versus, again, it's not a watermelon.
Yeah, and to think it'll have no effect. I think it would be a surprise to anybody who does that would have any effect at all.
Nobody's done any studies on either one OBGYN or whatever to look at delivery practice and how many of those children ended up with short or long-term concerns. The OBGYN is meant to have a child that lives, that's a successful birth. Go home and have a nice life. So they are not even involved unless you go back to that same person to have more babies. They have no...
Then it's the pediatricians.
Right. Whereas a doula has much more responsibility. They're more looked at is, well, how did that child turn out? Oh, look, there's problems here, so therefore, home birth's not good or whatever, or having that kind of relationship. So...
Opportunity as well.
Absolutely.
So I really think this will enhance everybody to a level of...
Oh, yeah.
So again, just here...
Even if you don't work with babies, I mean...
Then just here, it's just that simple. And I'll give you a scorecard that you can note it, but honestly, again, when I hear, C-section, it's 4 days in the hospital, the bells are going off. I wasn't able to feed, oh, ding, ding, ding.
Or... You know where my key is now? Only feeds on one side. Baby won't feed on both sides.
Right.
That's like, I know, Michelle told me. And then you say something about that and say, and also in their car seat they lean over that way. And also when I do, and I'm like, so she'll probably come to you. She'll be here in spring break.
But
bring her baby.
People argue with me.
No.
But no, they'll say like, well, my pediatrician hasn't, there's a baby coming in.
You know what?
The baby's coming, just got the helmet on Thursday. She's here for 2 lessons tomorrow. Nobody's mentioned torticollis.
But, like this lady, that's exactly what she said. Well, the pediatricians aren't concerned. I said, well, maybe we should go to baby chiropractic. Well, she'll do anything. She's a professor. She's out there. Well, no. We'll just let it straighten out. And I was like, you're right. No, not to just let it straighten out. So,
But that's what they're taught by the doctor.
I know, that's what the doctor says.
They'll figure it out. If not, about 10 months we'll look at neurology.
No problem.
I say this all the time.
Yeah.
And that somehow makes it acceptable.
Mm-hmm. Right, as if it isn't bad all the time.
Or worse, oh, my child did that, he's fine.
Great.
Good, so if nothing comes out well, do you want to take my child home? Because, you know, I got, you know, oh, he'll outgrow it.
Mm-hmm.
And if he doesn't?
Yeah. You'd think they'd be more interventionist. I mean, when
but again,
like it's a baby.
But nobody has established what you guys are learning.
Yeah.
Yeah.
And as long as this
It's
child's
outside of it.
eating, pooing, and sleeping, they're developmentally on track. Nobody considers the birth to 3 months to be the key periods of development. So now that you're sleeping babies on their back since 1992, then you introduce the 5-point car seat harness in 1994 to 1995. If you look at the graph of the increased use of those kind of car seats and autism, the graphs are almost the same. So if you have a baby that suffered some form of trauma, which again, you don't know, that's why even, see, in your condition, I can have 5 people with the same hips, they will move differently because of their life movements. But for whatever reason, you present like this, you get an MRI, you get PT, pain medication, of a baby presents crooked.
I know.
Just there's some baby massage videos on YouTube. Go check them out. It's like, so why are you getting the care and the child's
Well, I should have gotten
now.
the care.
Well, me too.
You know, then, like you, yeah.
I was 2 weeks overdue, 10 pounds 6 ounces. So I came out like a buttermilk turkey, and my feet started to club. So I had boots and bars, the Dennison, on my feet. At least my mother had enough intelligence not to do the
Surgery.
they wanted to put in artificial arches, which I don't think they do anymore, thank God.
Yeah.
But yeah, then I
Thank
really would have been a
God.
client for life. So my legs are all crooked, but I'm fine. I know how to move around them. But
You know, some people think even like the baby carrying things are restrictive for babies. You know, you put them in the backpack, you put them in the front pack, and everything
again,
it's all wonderful. And yet,
if you have a child that's passing, and then every week you're kind of doing an assessment, like,
yeah,
because that's
Well,
what
that
I'll
would
teach
be
you.
fine,
You go to put
but
on your
they
baby's,
don't.
you go
And
to
then
put on your
they're-
baby's diaper and stuff, and this is a time that you want to sit there and you know,
Give
or
them a
they've been in
little-
a car seat for 2 hours. When you take them out, this is the time when, so you're going to learn all those things. But if you've got a baby with trauma, oh, they're not happy in the car seat, or they're not happy. That's when I hear, like, again,
That's
there's no
right.
judgment here. So when a baby's not saying, oh, they're not happy, they're saying, in this position, I can't even swallow or breathe, lady, you know, kind of thing. So I cry just to get air in my lungs, you know, because you put a baby on that kind of an angle. So, and then that's where they'll resort to wearing them because they're calmer. Well, they're just saying, well, at least I can breathe in this
Yeah.
position, but
Yeah.
you're still not helping them. And then you might overwear them.
yeah.
That's also what I like about the newborn assessment is all you need is a baby blanket.
Yeah.
There's no eye gazing equipment. There's no equipment whatsoever. You don't have to be trained per se. I'm training you. You guys will be certified for this, but however, you won't be teachers just yet because without learning the movement lesson part, you can't troubleshoot. If someone comes to you with a very severe baby, I don't want to put you guys on a ledge just yet.
Which you could get there quickly. I mean, yeah.
Well, you know, if a person's born with a brain bleed and virus and all of this and microcephaly and stuff, and you're like, what do I do about my baby? Do you know what I mean? You need to be prepared to be able to do lessons afterwards. So, and that's all.
That's right.
So this is another way of looking at the spine, just sort of a creepy little the hand creep going up the side. Because again, you can see how the feet react properly. I mean, this child's a pretty good child. That's why, again, I like it so much. You can move where you've got just the finger underneath is another way of looking at it. But honestly, if you once you feel like, quote, stiff baby or a floppy baby versus this, there'll be no questions as to. Not all babies today will want to be touched by you guys just because, but with your backgrounds, and I think most of them will be open to at least to go just to try them out and assess the child. But we'll ask on a basis. Like Joy will be fine with you guys working with Cupcake just to feel her low tone per se. And we'll be doing this on each one of us so you can see. So as I mentioned, babies have a higher fluid rate. They come in around 85% fluid. Now, a premature child is going to have a much less fluid rate. A premature child also, their epidermis will be growing first, expecting the body to come into it, which hasn't happened. So you'll get where the skin kind of hangs. They kind of look like, I hate to say it, little chickens, you know what I mean, where the skin's hanging.
Yeah.
Now, I'll be showing you a baby that I did in India, and literally you can see the body plump up just as it's getting a lesson, and I'm going,
Wow.
this is so cool, you know. But again, the doctors aren't seeing the significance of all of that. But babies are also born with more bones.
Yeah.
They're
More bones? How can that be?
because of the way that they have to get out of the vaginal canal.
Oh, right. And then things fuse.
Right. The skull
like
is
the
being
skull.
one of them.
Okay.
But but also they're all cartilage.
Yeah.
There's no calcification going on. The calcification happens after. So already the way that you rotate and move, because of your limbs are longer, less fluid rate, you're now about the 60-65% rate, calcification changes. So your movement, your touch is going to be different than that of a baby's. Now those are things to be taken in consideration, but the reason that's significant too is what I'll be showing you is babies don't lift anything. Their heads, their hands, they transfer their weight. They're like little balls that roll around in that sense. I get it that they have a chest cavity, but as a baby starts to bring an object to themselves, they'll bring it in. If a baby out here is lifting something, once that lift happens, this stops. Automatic stop, and that's the earliest signs of cerebral palsy.
Wow.
So a typical baby will, they might grab an object out here, but they'll transfer it into them to make that ball one. Even a 2-year-old, when they carry something, it's against the chest cavity.
Yeah.
They won't be like, Mom, this is gross. They'll be like, Mom, what's this? It's gross. They bring it into them.
That's right. Well, and you know, even now as I have more trouble opposing gravity, I have to have stuff right here.
Correct.
I cannot do anything out, you know, like carry something or out there. It's like it has to be right here in order for me to be able to deal.
But
it's interesting.
But that's,
and that's good.
But that's the intelligent response.
Right. Right.
The unintelligent is when I get these seniors that are still trying to do Christmas lights and they're falling off ladders and they're going, but I don't understand. I'm going like, forget Christmas. You know, the fall is worse than the cancer and the heart failure that you're worried about. So when
Forget Christmas, it's off your list these days.
Another thing is a baby does not know its pieces and parts. A baby doesn't even know you're the mother, no offense. It quickly realizes that, hey, this person over here has got the good stuff, but so when a baby is born, when they have a preference, because babies don't have preferences, a typical baby will go, they won't even do out this. We call this going away from home. So they'll be here and here, just like in the womb. So suck, eat. Again, they should have this natural rotation. But when we say stuff like, oh, he always likes to look from this one side. No, the baby should be able to, quote, react to you as stimuli, but also react to that as stimuli in an equal manner. This is when you really should see that neutrality. Now again, if it's fussy and about to go to sleep, yes, you're going to see maybe more typical asymmetrical, but they'll go back. So a baby doesn't get stuck. A baby does not have habits, or that, especially to a preference, that they like to do that. He's only grabbing objects with the one side. So when those things start to happen, and this is where you're going to learn a lot about this week, is the vision starts to get organized or unorganized. So now let's say, even if it's a brachial plexus injury. So a brachial plexus injury is when the baby either got stuck in the vaginal canal, or again, the doctor grabs, somehow breaks that nerve, not breaks it, but traumatizes enough that the baby's
bruises it maybe.
That's dead to me.
Yeah.
Now, most kids, if they are left in that condition, they'll never have function of that arm. Now, I've done it easily. I've seen it not do it. You know, there are modalities that work with that. So the baby, and that's what I'll be showing you, is how they recognize a body part. But what happens if the body part is, quote, dead to them? So now I get much more stroke in utero.
Oh, wow. Yikes.
Oh, yeah.
I didn't even know that was possible.
Oh, yeah.
Some of these things she talks about, you're like, Jesus.
Yeah.
I mean,
I've
really.
seen
to work on
and
it.
then to work on it. Like, even just to hear about it.
Okay, if you had a stroke, all of your neural pathways have gone through your entire brain. So someone to say,
No.
oh, I eat from here, I see from here. No. There's no left brain, right brain. If I go to do something, it's synapses. We're one giant crystal ball. But when a baby has had it, especially in utero, I look at it this way. It's like growing up without a TV.
Yeah.
Would it have been optimal? Yeah. But if it's
right,
not...
that's right. There's all sorts of things
because
that could be...
now you remap.
Yeah, that's right.
If you can get to them soon enough. But
Wow.
if they don't know that they're capable of remapping,
Yeah.
and this is the significance of this work as you go in to start to touch and work with the baby, is that you're touching them in a way as if they're doing the movement. So their brain doesn't know, oh, Michelle's fixing me. Their brain's going, oh, wow, ball, cool. And it starts functioning. So let's say it's a brachial or stroke or something like that, that this side is just laying there. You'll start to see also now visual adjustment, because I'm only getting a hand response, eye response from here.
Yeah.
This hand's coming up. So if a baby can't see it, it doesn't exist. Torticollis, if a baby can't see this side, they're not kicking their feet up. They're neuromopping, it's not happening. So even too, with these stretches and the stuff that they do for torticollis, which I'm really against, you're still not working in, and this is where movement lesson comes in.
Yeah.
Underneath, like, oh, there's a ball there. And now sometimes what I'll be doing, especially when you're seeing more the cerebral palsy start to kick in, where the eyes now are beyond the horizon, I'll float the beads here, or I'll have one of you floating the beads here. So in their brain, they're getting that eye-hand connection until I can get them to come back here and actually go after that eye-hand connection. So that stimuli is there to influence their system. Again, if you were to have a stroke, you're more caught up with, gosh, why can't I do that again? Because again, someone took those synapses and maybe, it's sort of like a lamp that's not plugged in.
Yeah.
It might have all the tools, but unless that electricity is there, it's not happening. So, but with a baby, again, I'm looking at it more like it's wires kind of crossing, and it's like, and gets that short. I'm going in and trying to say, oh, look, that's all connected. You've got the
Well, I mean, that's the beauty of working with the babies, is that they could, there's lots of ways this could go. I mean, it's very...
and because there's no judgment,
Yeah.
it's just going, woohoo, this is cool.
Yeah.
Whereas, again, for an adult or something, how long will this last? And, where am I going to go with this? And am I cured? Or, But again, the conversations you're going to have with the baby are different than adult conversations. I can lift something out here, right? But 10 and under, a 10-year-old or younger will put an arm down until this starts to happen. I have superior balance and counterbalance. That comes after years of going, oops, that didn't work, or oops, that did work, oops, that did work. And so my filing cabinet has gotten into a habit or things. Now again, what happens with adults? I only know how to do it this way.
Well, see, that's where we go. That's where we go. We teach lessons and we say, keep everything on the floor. So we're going to do this. We're going to bring our hand, and you're going to keep your hand on the floor, and you're going to keep your foot on the floor. Because people want to do this. They want to come back and do this rather than go the easy way, which is...
Right, but an intelligent person should know that they can do both if they have to.
Well, yeah, right.
But so, but again, that kind of intelligence is not in an infant. This is where, again, a lot of therapists come in and expect this baby to have an adult cognitive response. I'm trying to teach you guys really how to think like a baby once again. Because...
which would be good for us, too. Yeah. We forget.
We do forget, but also we're not taught.
Yeah.
I look at it that there's an infantile response to stimuli, and then there's going to be an immature response to stimuli, which is anywhere from, like, let's say 2-ish to 16. Like a 2-year-old doesn't have mind over matter. They might be obstinate, but they don't have, I'm determined to climb this mountain no matter what. And yes, it's raining today. That comes way later. 16, and some people never get it. Yeah, it's raining and I'm not doing it. That's right. But no, you still have a degree. I mean, you know, you've done it. But again, as a child, you know, if it happens, if it doesn't happen. But those are the things too you'll start to see in the little munchkins. Some of them are just determined, I'll throw anything out, and that's what you see with drugs. You know, I can kick that ball with my feet, great, I don't need my hands anymore. So they won't look for any kind of efficiency. I've touched it, I've gotten a response, woohoo, we're good. You know, so it's a much more shorter synapses versus that happens, it should happen around 10 months of age with a very smart baby. And again, I don't mean to say that, but because of experiences, babies will have where they'll actually start to look at an object of where that object is in space. And also around 10 months, an on-track baby will start to combine two objects, seeing if it'll do something different. So they'll have a ball or two balls and they'll start banging, or, oh, I got a noise from it. So they'll try to create something from their environment versus just to attach to it. Whereas, again, by that stage, a big warning sign is where they're flapping or shaking, but they're not even
doing anything with it.
Yeah.
Yeah.
Yeah. I really, it shames me too, where so many parents are like, "Don't put that in your mouth." I'm like, "Oh no, ixnay on that. They really need to."
Well, they're gonna, whether you say it or not.
But that experience is very important.
Yeah.
So much, yeah.
Well, they learn gravity, where they are in space, but also how heavy is that object? Is it a solid? Is it the jaw is, everything going in the object, in the mouth, is gravity as well as the anus. Those are the two orifices for the senses. One of the things I'm starting to write up, we are taught we have 5 senses. And every sense has 2. So there's 2 eyes, 2 nostrils, 2 ears. It's the mouth and the anus, 2 hands, 2 feet. So there's 2s in all of our the way we set up senses. And those 2s come important with the breast tissue. So when a child is learning how to nurse, first of all, it's getting a bilateral feed, right and left. But also when the nursing happens is the pronation. We actually start to search for our food. If we watch the way we eat now, we bring our food, we meet our food. So a bottle-fed baby now, the food's coming to them. And worse is the NG tube, because the NG tube now also, not only are you interrupting swallowing and breathing reflexes and all of that, but the tape on the stuff, you'll start to affect not only the neck muscles, head muscles, spine muscles, hand function, all of those will get affected just from an NG tube. Now again, I'm not saying don't feed your baby. What I'm saying is start noting these things, but that's where you have to go in and offer that baby opportunities to learn when they're not normally getting it. So another significance with nursing that'll start to happen is the baby will start to play with the breast tissue. That is a pre-indicator to me is standing. Because what that's doing, that's the first time the baby is learning about that 2 oppositions of forces. I'm pushing in and I'm sucking. So I'm actually feeling that pull, which again...
Because it looks like that when they do that. You're right, it looks like they're...
Right, it's a little push-up, it's a pre-crawl. It's all of those things are meant to happen off of that. So when you go to stand up, your feet go into the floor and the head comes up and the baby comes away from the floor. This is what happens. So with the nursing, but also what's really significant that nobody looks at is digestion is done on a rotation.
Yeah.
So when I'm nursing, right, look at what it's doing to my digestive stresses. So I believe that's why babies that are breastfed aren't typically constipated babies, because they learn how to have bowel movements in this position. They learned how to digest food in this position. They learn how to do it, so if you do a football hold, if you do this, if you're standing up, they're learning how to have breathing and all these functions coming over. And I'm breathing and eating at the same time. There's so many key development factors that are happening that in a bottle-fed baby, well, you try and eliminate when you're just lying down. You know? My colon's not doing anything. So now when I later on start to crawl, oh my gosh, how am I supposed to crawl when I got this load of, I just had a bottle, now you've got a higher refluxy baby and all of these kind of things because the food's not digesting. So even if you're a bottle-fed parent, is there a way, so if I'm just, let's say I'm bottle feeding this child, can I bottle feed it more here? Again, where I'm touching the hands, bringing it in, and offering all of these kind of things with the mouth. And again, I'm right-handed, so most bottle-fed babies then only get a right side feed. Come on in. Hi. I'm just finishing up here with the difference between bottle feeding and breastfeeding. But again, to give that child a bilateral experience of feeding on both sides.
That's huge.
Huge. If all they did alone was offering this kind of opportunity to feed in each, you know what I mean, when they can't. You know, if you want to go as far, even though if you're not feeding, you still can bring in breast tissue into that to let the baby feel and play, and just like it was an object or a ball. You can still do all of this and these kind of things that happen that, again, aren't being gotten. But they look at breastfeeding, the only argument is for nutrition, really. But the developmental movement patterns on breastfeeding are just so substantial and just so natural. It's the ultimate bonding that you get to have. And again, adopted parents don't have it, or foster parents and all of this kind of thing. But there's ways of offering that opportunity. Even if you're just here working on a suck reflex with your thumb, because a suck's going to be different off of a breast nipple versus a bottle nipple. But again, just to be back there like this, and what's worse, baby in the car seat, they put a little blanket here, they put a bottle on top, and they sit there with their foot, and this baby's basically getting rocked. I'm like, if you can't pick that baby up to feed it.
Look at her. She's like, I don't even want this.
She's like, nobody does that for me.